LDA was invited to speak at this conference to give a view from a patient organisation. Some of the audience might not want to listen to a talk by patient organisations, so I thought I'd start with an unexpected slide. I said they might wonder why this talk is in the epidemiology section. As a patient organisation, we have dealt with what feel like epidemics, but not those caused by biological pathogens. These cause problems for all of us. The first type are fast-moving and they come in waves. They are epidemics of misinformation. All of this impacts the patients and we have to navigate it and help people through the maze. It does also affect doctors. Then we have the reaction. Slow-moving epidemic in health professionals, the papers in medical journals that influence doctors. In the UK, the Chief Medical Officer Bulletin printed, "Those claiming to have chronic Lyme disease or who believe it to be the cause of their chronic condition can be diagnosed definitively." This wasn't actually the fault of the CMO, as she was given the text by someone else. However, this epidemic of papers led to a chronic, lasting condition in UK doctors. It convinced them that patients are anti-science and there's no such thing as continuing symptoms after Lyme disease. Then from the Netherlands in 2011, a stake in the middle ground. This reflected what a lot of us thought and came from a very well-respected medical centre. The paper stated, amongst other things, that doctors should not say, "Your treatment has been adequate," or "treatment never fails," because we don't know that. My talk was the view from a patient organisation, and I said that we can't talk for all patient organisations. Some will disagree with us, but most will share some of our view. I then showed a slide to put the UK Lyme disease in context and show how in the UK, because we haven't had Lyme disease for as long, we are behind most of Europe. Doctors in practice now were trained by people who had never seen Lyme borreliosis. The language in the UK, when a patient accesses social media and information, they may well be reading something from North America. The USA is different. Different ticks, different tick-borne diseases, different healthcare system, and different culture. The polarisation of views along the ILADS IDSA fault line has been high profile in the UK and still is. The Borrelia in ticks. We have a different disease. In the disseminated Lyme disease, we probably have a lot more late diagnosed, and there is so far little interest from doctors in a specialist clinic. Most of the trials that are used to inform our doctors are based on European trials on that slightly different disease. And we have few clinicians because this is an emerging disease in the UK and we have fewer cases. I then explained how we tried to change the UK view. I told them that when we started this project with the James Lidd Alliance to find the research priorities, that the Department of Health refused to support it. And the Chief Medical Officer actually said in a letter to us that she trusted that the project will help patients to better understand the science of Lyme disease. You can imagine what this felt like to a science-based charity. Once again, this was not the CMO's fault. These were words given to her by someone influenced by that epidemic of misinformation amongst health professionals. The first JLA survey was to ask patients and clinicians what their uncertainties were. I related to the conference how one anonymous infectious diseases consultant actually submitted, "I have no uncertainties in Lyme disease diagnosis or treatment. I know where to find evidence-based guidelines." I pointed out to the conference that this person had clearly not read the main guideline, as that states that most of the recommendations are what they call good practice points because of the lack of quality evidence. This was someone else influenced by that epidemic of misinformation. The James Lind Alliance project proved that there were uncertainties in treatment and diagnosis, and we developed the top 10 research priorities. So I told the conference that after that, we had to take evidence-based information to the doctors themselves. So we attended medical exhibitions. This was really useful. Having Dr. Sandra Pearson there, our medical director, was of huge benefit. We went to conferences, Europe and America. We went to learn. We exchanged views with health professionals and particularly researchers, and this is how we developed relationships with many of the people I was talking to now. I then explained that although we are an organisation run by patients, we do not work solely for patients, but we work for all stakeholders. We provide information to many groups, and we try to understand their perspectives, which are not always the same as what patients see. Because of this, we need to know a lot about aspects of tick-borne diseases. Ticks, removal and repellents. People going on holiday, tick removal in Australia is very different, and people writing travel guides need to know. We need to understand more about Borrelia, the tests and their limitations, and so on. To help all these groups, we need evidence-based information. If we are asked, say, about sexual transmission, breastfeeding, etc., whether by a patient, a journalist, or health professional, then we have to know what the research says and provide those references. We can't just say, it doesn't happen. Is ultrasound a help in repairing nerve damage? We have to find out. I showed them this slide of our library, nearly 3,000 scientific papers which we catalogue and read. I explained that some years ago, NHS England realised that there was a problem with health information and devised a system to accredit information providers. We are accredited to the Patient Information Forum PIF-TIC, and we have to prove that we have processes in place, we review our information, and we use trusted sources. I made the point that patient organisations in Europe are run generally by patients or relatives of patients. This is personal and why patient organisations have strong views. We know symptoms can persist, but no clinicians believed it. It has taken a long time, but finally this study reported genuine persisting symptoms. Scientific papers always have an abstract at the beginning, a short summary of the papers. Doctors might read the summary, but not the long paper. I explained how we can quote this abstract to help move things forward for patients in a discussion when writing to their GP. Systems can persist. However, there is a sting in the tail. The same group of patients was studied to find out what determined their continuing symptoms, and this is where the abstract is no use to us. The summary basically said that these patients were anxious and that might explain why they noticed they had continuing symptoms. To a doctor reading just this abstract, this says this is all in their heads. However, if you actually read the paper, you find that what the abstract doesn't say is that these patients were treated very early, a mean duration of symptoms of 6 days. I said that to us, the paper indicates that these were the patients who worried about what they read on social media. They had contracted Lyme disease and were really worried about what was going to happen to them. They felt every ache, every tiredness, the sort of things that before getting Lyme disease they considered part of life. So I proposed that maybe their persisting symptoms were possibly caused by social media, that first epidemic of misinformation. I pointed out that in the UK, patients are finally treated weeks, months, and sometimes years after contracting Lyme disease, not just 6 days. I told them that in the UK, if someone with late diagnosed Lyme disease has continuing symptoms after treatments, they are likely to be told, "Oh, your MRI is normal. You have nerve damage which takes time to heal. Your blood test may stay positive for a long time." I said that what no one seems to say is that at the actual fact, at the moment, we don't know what is going on. We have these late diagnosed patients in the UK with persisting symptoms, and this research is not happening here yet. If we are to find answers, we need to look deeper. Then I drew their attention to a couple of worrying papers. The first paper said, after treatment, a third of these patients with Lyme arthritis still had joint problems, some of them in previously unaffected joints. Was infection still present? No way of knowing, but they had a negative PCR on joint fluid now, so probably not. They were treated with disease-modifying anti-rheumatic drugs, helping a disrupted immune system. They got better. Then this year, a case in the UK. Despite 4 weeks of doxycycline and 4 weeks of ceftriaxone, the patient continued to have flares of arthritis, but a negative PCR on joint fluid, anti-TNF treatment, and got better, again addressing the immune system disruption. What is worrying about this? Why have I said the worrying view? These patients were believed. So if you are lucky enough to have had Lyme arthritis, you may have a raised CRP in your blood levels, a still swollen joint, objective signs that a doctor can see and believe. So someone wonders if your immune system is acting up and tries a drug. Bingo! I asked if there were any immunologists out there investigating. In cases of persisting pain, what can we measure? What can we try? If we don't look, we won't find. Okay, I said our view is that we need research. I said it's difficult for a patient organisation to initiate research, though we can see many things that need answers. Few UK researchers have an interest because they've been told there is nothing to research. That epidemic of misinformation. Ticks, yes. Lyme disease, no. When the NICE guideline was published, recommendations were made that no one could argue with. One of these was the need for a core outcome set. When doctors ask someone after treatment how they are, what actual outcomes do they record? Studies use different outcomes, so it is impossible to pool results to get better information. I told the delegates that we are funding researchers from the COMET initiative to develop a core outcome set. COMET is hosted by the University of Liverpool and has worked internationally to produce outcome sets for many conditions, including complex conditions like post-COVID. I said we are about to get underway with the surveys about which outcomes are important. What should be measured in a study of treatment? I said that they needed to be aware that core outcome sets are now endorsed by the World Health Organizations, so they will need to use the Lyme core outcome sets, and they all need to have a say in this development. I asked them if they would please visit this website and simply register their interest. Doctors, researchers, patients are all invited to participate. What now is our current view? 22 years ago, when LDA was formed, there was a brick wall. When we achieved proof that there were uncertainties, we thought we had broken through the brick wall, and academics and health professionals would talk to us, but that didn't happen. They stayed with their backs turned. Some talked to us to tick the patient participation box, but that is all. However, there is a window opening through which we are at least able to talk to Europe and to a few in the UK. Perhaps it won't be long before we can contribute, for our thoughts, ideas, views to be seriously listened to and taken into account. I mentioned a paper that had just been published. The Microbiology Society in the UK says it has begun its journey to address the long-standing challenges of an inclusive culture. However, in that culture, they do not mention patients. Though I admit some years ago they did ask our medical director to speak about Lyme, but she's a doctor. I told this group at the conference from Europe that given the North Tick project, where they included patients, and this conference, that they were clearly ahead of the game, as they have invited patients to speak and to contribute. I thanked them. I also thanked patients and the public who not only have supported us with donations, but also importantly ask us questions to help our understanding of the problems. Thinking back on the conference, we still have a long way to go, but the view has improved from 20 years ago. If anyone wants to help on this road to a better understanding of what we're dealing with, please get in touch, whoever you are. Thank you.